Our heart goes out to them and their families. Structural and functional correlation in the diagnosis of glaucoma is vital for diagnosis of glaucoma. The aim is to give lucid instructions on how not to miss glaucoma in your clinical setup. In India, up to 90% glaucoma is undetected and about 50% is overdiagnosed. Hence, there is a need to impart practical clinical skills that shall help in increased detection and reduction of overdiagnosis. Structural and functional correlation in the diagnosis of glaucoma involves, at the beginning, the moment the patient comes to you in your clinic, what is the thing that you do first? The slit lamp examination. To lead you towards glaucoma, the most important thing that you must do and develop and make it a habit is to see the anterior chamber depth. The pupil striatus, the pseudo-exfoliation, atrophic patches on iris, Krukenbrad spingle, etc. And Van Herrick's test is the way to go to see for the depth of the anterior chamber. The highlights of this, after this, will be to see for the optic disc. And here, Dr. Medha Prabhudesai Nitin will be speaking on evaluation of optic disc in glaucoma and OD suspects. Structural evaluation of optic disc and the must-look-out signs shall be outlined. The next talk will be on understanding posterior segment OCT in glaucoma along with structural and functional correlation. If you suspect something in the optic disc, how to correlate it structurally by imaging technology, Dr. Amit Porwal will highlight the role of imaging for confirmation of structural defects, especially in the disc suspects. Then, interpretation and functional correlation of structural defects in glaucoma and visual field that I shall be taking over, and I will be speaking on correlation of diagnosed structural defects with functional changes in visual fields, including correct interpretation of a field printout. But at the outset, all speakers shall give a take-home message and also demonstrate structural and functional correlation in an interactive style. The expected end result of this session shall be that the delegate be able to confidently look out for and diagnose glaucoma. At the outset, we have a keynote address by Dr. Neeru Gupta in this session. She will be speaking on glaucoma damage from eye to the brain, implications for treatment. I welcome Dr. Neeru Gupta to give her keynote address. Thank you.
Giving a short introduction of Dr. Neeru Gupta. She is the head of glaucoma services in the University of Toronto, and she is the vice president of International Council of Ophthalmology. So Dr. Neeru Gupta, she's going to talk on glaucoma damage from the eye to the brain, implications for treatment.
Thank you very much for having me. I'm so excited to be for the first time at the All India Society meeting and among colleagues and so many friends. And thank you for the invitation from the organizers. Thank you very much. So does anyone recognize this person? This is a woman who presented many years ago, almost 100 years ago, to a physician in Germany. She presented with a bit of confusion, agitation, and this happens to be the woman who presented to Lois Alzheimer and first diagnosed with Alzheimer. And after she died, he looked at her brain under the microscope and was the one to first recognize this senile classic plaque, which to this day remains the corner hallmark of Alzheimer's disease. When we think about that particular disease, it's 27 million people, mainly 60 and older, progressive loss of memory neurons, and decline. Now look at glaucoma. We have 80 million people, mainly 60 and over, loss of vision neurons, and progressive vision loss. And we all recognize this as glaucoma. We have loss of the inferior rim, a disc hemorrhage. And I want to share with you a little bit of a journey that we had in undertaking our understanding of whether the changes that we see in the eye are actually evidence of a broader, bigger picture. This is a graph of where we had monkeys and we raised pressure in one eye. You can see the high pressure spike on one eye, and the other fellow eye was untreated. And after treatment, after lasering the meshwork to drive the pressure up, we looked at the optic nerves, and you can see the big fat black nerve that has about 1 million myelinated nerve fibers compared to, in the healthy control, compared to those that are affected by the high pressure. So you can see there's very little nerve fiber left there. But you know, when we look at this by electron microscopy at the optic nerve and we cut, they all look the same. You know, if you cut the optic nerve and you try to differentiate the neurons, we don't know what's what. Luckily, the eye is beautifully organized such that the cell bodies, the axons of the retinal ganglion cells actually terminate in the lateral geniculate nucleus. And there is an exquisite organization, both anatomically and functionally, that allow us to differentiate between magno in the first 2 layers, parvo in the dorsal four layers, and sandwiched in between we have our coniocellular neurons, which are responsible for blue-yellow signal. And what we found when we sacrificed these monkeys, when you raise the pressure in one eye and you look at the lateral geniculate nucleus, actually the lateral geniculate nucleus is affected, it's shrunken. And on high power under the microscope, if we label these neurons with calmodulin, what we see is compared to the normal plump, round, neurons on the left, you see that there are sparse, fewer, shrunken neurons. So we said, well, we need to measure it because in science we have to measure things. And so when we measured the number, we found that compared to the normal lateral geniculate nucleus in that brain center, 50% were gone. And so this was published as, evidence that in experimental monkey glaucoma, if you raise pressure in an eye and you look at the brain, the neurons die. So then we said, well, what about the cells that are left behind, the ones that didn't die? We found that they actually shrink. There's a shrinkage to the left. So you see the control is in red, and the green is the size measurements at all distributions, and there's a shift to the left. So we published this, and we said, for the ones that are left behind, there's shrinkage in glaucoma. But then we said, well, those studies were looking at specifically magno and parvocellular. What about the coniocellular? What about those, the yellow-blue pathway? These ones are sandwiched in between. You can see on your right, these neurons lighting up with CAMK2 alpha. When we look in glaucoma, again, they're significantly reduced. So we published this and we showed that 3 major vision pathways in glaucoma are affected when you raise pressure in an eye. And so it goes to show that if we have damage in the lateral geniculate nucleus, naturally one would expect that their projections to the visual cortex might also be affected. So we said, let's look at the visual cortex. And in the same monkeys, what we found is that in normal visual cortex, if you label it with cytochrome oxidase, which is a metabolic marker, you should see a homogeneous, even staining as you see on the top. But in glaucoma, you see alternating dark and light bands corresponding to the lower levels, which are driven by the glaucoma eye. So again, if you raise pressure in an eye, you see changes in the lateral geniculate nucleus, and they can be seen all the way to the visual cortex. So in primate glaucoma, we were fairly confident to say the neurons shrink, they die, all pathways are affected, and it goes to the visual cortex. So that's fine. These are animal models. What about people? So are they relevant? So let me share with you a case. This was a 79-year-old Caucasian gentleman who presented to me with open-angle glaucoma at an advanced stage. He died 18 months later. He had 0.9 cups, but he had previously consented for organ donation for research. And I'm going to show you what we found just before the chiasm at the level of the lateral geniculate nucleus and also in the visual cortex. So if we cut right before the chiasm and this is our case compared to age-matched controls, we see that there's a significant shrinkage here. This is neurofilament stain. And if we look at the lateral geniculate nucleus, we see again the glaucoma through the biggest cross-sectional area. The lateral geniculate nucleus is smaller. And when we looked at his visual cortex, we found actually that he had a shrunken mantle. And so this was evidence that validated our findings in experimental glaucoma that said, you know, when you have human glaucoma, it's associated with degenerative changes in major vision changes centers of the brain. And this has really changed our understanding and even the way that we've defined glaucoma. And so this was published. But we said, well, what about patients who are in our clinics? Is there any way that we can look for this evidence? So we used 1.5 Tesla MRI available in any general hospital. We looked for the lateral geniculate nucleus. We blinded the 3 neuroradiologists to measure in our glaucoma patients compared to control population all of the heights of the lateral geniculate nucleus, which they often use in hippocampal studies to look for Alzheimer changes. And what we found was that there was atrophy of the lateral geniculate nucleus in the human glaucoma detected by MRI. This is 1.5, and since then there have been many other studies. So there has been an explosion of interest in seeing the brain, whether we're looking at microperfusion, structure, activity, or connectivity and metabolism. And here's an example of something that comes out of Japan. Here's another study that is looking at, you know, the visual pathway with DTI, diffusion tensor, different techniques to look behind the optic nerve, where here you can see 3T MRI Tesla, and it goes on. Here's something that identifies cortical changes, and if you do a literature search, you will see it's just the slope has really gone up in terms of the corroboration around the world using various approaches and techniques. So what we know is that in glaucoma, using structural MRI, things go wrong with the lateral geniculate nucleus. We know that even with the matter tract optic radiations in glaucoma, there are problems. And when you look at the visual cortex and beyond, there are significant changes there. So when we're trying to understand glaucoma, if you see all these changes, the contacts are destroyed, clearly this processing of the visual signal is disrupted, and it's understandable that we would have loss of vision. We've talked about the retino-geniculocortical pathway, but there are also retinal non-cortical genicular pathways involving the superior colliculus. Now, the superior colliculus is very good and important for eye movements. So we wanted to test out to see, is it something going wrong there? We used saccadic eye movements as a test. And we found that actually saccades, which we use for every day, looking quickly at our environment, scanning, going down the stairs, looking through the grocery store to see what items we want, they are delayed and affected. Could this explain the falls? Could this explain some of the driving accidents? So we see that if we look for it, we are seeing changes throughout the visual system in glaucoma, and there's a real opportunity to exploit these changes for repair, because right now all of our targets are on the eye. So the take-home message in closing is really that glaucoma is extensive disease involvement, and the visual brain is affected early, it's a biomarker, it's promising as a tool, and there's really some big opportunities to slow disease progression. So maybe we should target the entire pathway and the patient. And in closing, the next time that you look at an optic nerve, maybe we can consider in the clinic that this is just the tip of the iceberg. Thank you very much for your attention.
Thank you, Dr. Neeru, for that enlightening talk. Now, the next speaker will be Dr. Medha Prabhudesai-Nitin. She will be speaking about the optic disc.
Audiovisual person, the monitor is not working. Please check it. Audiovisual. His monitor is not working.
Good afternoon, everybody. Now I would like to see how the optic nerve behaves in glaucoma. So though it is a tip of the iceberg, as Dr. Niru had said, we know that that is only structure, what we can see clinically, and let's look at the clinical signs of these. Once you go through this, I think it would be possible for each and everyone to find out if the patient has glaucoma or not based on this, and then you can have ancillary tests to determine whether what you think is actual glaucoma or something else. So examination of the optic nerve head is one of the simplest and most overlooked skill in ophthalmology. Though it is challenging, once you know what to look for, it becomes very easy. Once the brain knows, once the mind knows what is there, then becomes very easy to find out these signs in glaucoma. So coming to basics, how do you evaluate the optic nerve? You can have direct ophthalmoscopy. Obviously, it has limited advantage and lacks stereopsis, but you have slit lamp microscopy also, and 60D, 78D or 90D non-contact lenses you can use to evaluate these things. Goldman size 4 mirror also can be used, and it helps us in having stereoscopic examination. Obviously, detailed drawing should be done, and this is the method directly how to see what is the size of the optic nerve. This is also important. So what we call as a gross technique. So you have a Welch-Allyn ophthalmoscope, and 5-degree aperture of this can be used to see set a circular spot over the optic nerve head, which is comprises of 1.5 mm. So if your optic nerve head is fitting into this or it's more than this, so it's the simplest way to find out whether the optic nerve head size is below 1.5 or above 1.5. The next is with slit lamp biomicroscopy and handheld lens. You have to adjust the height of the slit lamp beam to coincide with the edge of the optic disc as shown here. So, and read the scale on the slit lamp which is there. And then you have multiplication factors. So for the type of lenses you are using, you have different multiplication factors. So you multiply the scale which you have read on slit lamp with this factor, and you get the size of your optic nerve. So that is the simplest way to find out the optic nerve head size if you don't have any other methods. So documentation can be done with the help of color and red photographs. Stereo photographs are preferable. You have to have a baseline photograph and serial photographs to find out whether there is any early change in the optic nerve head which you are following up. So normal ONH we know follows ISNT rule, and horizontal cup is much more than the vertical cup. Size of the optic nerve head is commonly described as the horizontal CD ratio. It varies widely in normal population. CD of more than 0.7 is seen in very small percentage of population, and disc asymmetry of 0.2, that is CD more than 0.2, is seen in only 1% of normal population. So what is physiologic cup? So these are the large discs with large cups. So these are symmetrical in both eyes. They are similar in parents and siblings and genetically determined. So this is again another example of physiologic cup in a moderately large disc. There is physiologic variation. There can be discs which are small size, usually less than 2. 2 to 3 are mid-size or moderate sized, and more than 3 we consider as large size discs. So how to find out the disc size if you have stereo photograph or with the help of a circle? So this is the fovea centralis, and this is your optic nerve head. And now if you see, almost 3 circles are there till you reach the fovea. So this is a small disc and a small cup. Now let's see this is fovea centralis and this is the cup. So almost 2 circles are needed to reach the fovea centralis. So this is, you can consider as having a moderate disc, and this is fovea again, and just 1.5 circles are needed. So this is a moderately large disc. So this is the simplest way to find out. Now how to find out neuroretinal rim. So here you have to identify the edge of the disc, that is the scleral ring all around. Then you observe the blood vessels, how they traverse in the cup and how they come over the neuroretinal rim, and then you can find out this is the neuroretinal rim over here. So this is the way to find out the neuroretinal rim based on blood vessels. The next is again follow the course of the blood vessels within the optic disc and how they come up over the neuroretinal rim here, superiorly here and inferiorly here. So you know where the inner margin of the neuroretinal rim starts, and that is the way to find out the neuroretinal rim here. Next, you know these are the circumlinear vessels and they rest on the neuroretinal rim. So this is the inner margin of the cup. So if you see a neuroretinal rim, you know where the circumlinear vessel, you know where the neuroretinal rim is there. Coming to tilted disc syndrome, this should not be confused with glaucoma. This is a congenital anomaly of the optic disc and it is non-hereditary, usually bilateral condition. Superior temporal disc is elevated and the inferior nasal disc is posteriorly displaced, and this is a oval appearing optic disc which is obliquely oriented. So this is a optic nerve which has a congenital tilted disc, and you can see that this disc is elevated and the inferior nasal is depressed. Coming to tilted discs in myopia, this is always temporal and this is associated with enlargement and stretching of the eye. There is temporal flattening of the ONH margin. Visual field may show enlargement of the blind spot. So this is a tilted disc. You can see that there is atrophy, hardly any neuroretinal rem is seen, but here the neuroretinal stem starts where there is bend in the vessel over here. So now coming to optic nerve in glaucoma. So there are signs of glaucoma. Why they are there? There can be enlargement of the cup, and this is because axons degenerate and they occupy less space in the scleral canal. There can be thinning of neuroretinal rim because of loss of neural rim tissue. Deepening of the cup is there because of posterior bowing of the lamina cribrosa, and obviously thinning of RNFL because of loss of axons. So various signs are there. They are divided into these signs related to ONH size and shape, vascular signs and peripapillary changes. These are the ONH signs, and this asymmetry is the most suspicious sign of glaucoma. This includes asymmetry in size of the cuff, width of the NRR, vessel course and peripapillary atrophy. So this is a disc asymmetry. If you see the optic nerve here, this optic nerve is also large and the cup is also large. So this is a typical disc asymmetry which we have to see and follow up these patients regularly if they are to see if they develop glaucoma or not. And this is a gross disc asymmetry. This is a totally normal appearing cup and neuroretinal rim, but here you can see that there is thinning of neuroretinal rim all around 360 degrees along with bayoneting of vessels and other findings. So this is a typical disc asymmetry in a patient with glaucoma. Vertical enlargement can be there, but vertical enlargement in a patient where the disc is vertically oriented can be totally normal. So that you have to find out whether the disc itself is vertically enlarged and find out whether it is a related to the glaucoma or a physiologic variation. But vertical enlargement, bipolar notching associated with a RNFL defect over here, which we see here, is definitive of glaucoma. Focal notching, nothing notches optic nerve like glaucoma. So focal notching, if you are seeing along with associated signs here, RNFL wedge defect, thinning of NRR and other signs, even the pallar cup discrepancies here. So this is again a typical of glaucoma here. So this is what we call as pallar cup discrepancy. The pallar is much more, but the cup margin, if you see, it is there. So pallar cup discrepancy is a pathognomonic sign of glaucoma and points us towards further investigations. Now, sometimes there can be concentric atrophy if the patient has already high CD ratio, and if it is associated with inferior wedge step defect and a notching over here, that is glaucoma. So next, laminar dot sign. This is because of the exposure of the lamina cribrosa, because of loss of neuronal tissue in the cup, and this is not a definitive sign, but if it is seen, you have to again look for other signs and other investigations for glaucoma. Saucerization can be there because of the excavation of the cup margin, and very thin neuroretinal rim is there here associated. So this is called as saucerization. Advanced cupping, obviously there is thinned out neuroretinal rim, and other signs are also there which we see. There are, so this is called as, this is due to advanced cupping. Another example of advanced cupping is there. Now coming to vascular signs, splinter or trans hemorrhages can be there, and this is a significant finding. This can be a first sign of glaucomatous damage. It precedes RNFL defect, notching and visual field defects. This is seen more commonly in patients with NTG, and if the patient is non-compliant or if there are high IOP fluctuations. Common location is inferior temporal quadrant, but also can be seen in superior temporal. It disappears over some time and may reappear in new location, and this indicates that the patient needs more aggressive treatment. Coming to bearing of circumlinear vessel, this is because of the loss of neuroretinal tissue, and here there is very obvious bearing of circumlinear vessel over here. Next is bayoneting. So bayoneting is sudden change in direction of the vessel as it comes over the neuroretinal rim. So this is a change in the direction, but it is going through the excavation over there and coming on to the NRR. So this is called as bayoneting of the disc vessel. What is overpass cupping? See these vessels, there is loss of neuronal tissue over there, and these vessels, they come and fall in the cup like this. So this is called as overpass cupping. So because of the unsupported vessels over there, they appear that they are passing over the cup and suddenly collapse into it. Tortuosity of vessels can be seen because of chronic ischemia, and they represent loops of collateral vessels or venovenous anastomosis. Coming to retinal nerve fiber layer defects, these are the retinal normal RNFL is seen as light striations from bundles of nerve fibers, and they are better visualized at posterior pole where they reach a critical mass. So better seen with green light or red free light on slit lamp. So these can be slit defects, wedge defects or diffuse loss, and also peripapillary atrophy can be there. So we will see these by one. Superior slit defects can be, as I said, superior and inferior pole, and this can be first sign of glaucoma. They usually precede disc changes and field changes, and they have 85% specificity for glaucoma. So these are the slit defects which you see here can be totally normal because they don't reach the optic nerve head margin. The caliber is less than the retinal vessel, so and they appear and disappear over time. So these can be totally normal RNFL defects. But if you see defects like this, if you collectively, you can see that the caliber is much more than the retinal vessel. So these can be suspicious slit defects. Now coming to this defect, if you see there is a retinal hemorrhage over here and the defect is there. So and again this one more defect is there superiorly also. So this RNFL defect is suspicious of glaucoma and needs close follow-up for this patient. This may not be picked up on OCT as well as may not be picked up on visual fields. So you have to do serial photographs to see whether this defect is widening or progressing further. Now, wedge-shaped defect you can see superiorly and inferiorly, both wedge-shaped defects over here. So this is again a typical pathognomonic sign of glaucoma. And there is diffuse RNFL loss in advanced cases of glaucoma. So just to highlight, not totally normal RNFL, very subtle defect may or may not be glaucoma. Here disc hemorrhages are there, and a typical slit defect of glaucoma, a wedge defect, bipolar wedge defect, increase in the wedge defect of the glaucoma, and diffuse loss almost 360 degrees, some few fibers are seen here. So coming to peripapillary atrophy, there are two types of alpha zone atrophy is there and beta zone atrophy is there. Alpha zone is a irregular hyper and hypopigmented RP irregularity and can be seen in normal patients also, whereas beta zone atrophy is more frequent and more extensive in patients with POAG and NTG. Location and extent of zone beta correlates with visual field loss. So here is the example. So this is alpha zone irregularly pigmentation, and beta zone, if it is there, the alpha zone is pushed away from the optic nerve head margin. So what is this? Now we'll see one by one. A focal atrophy is there. This is a bearing of circumlinear vessel and laminar dot sign. This is next patient. You can see that there is bayoneting of vessel over there, thinning of neuroretinal rim, and pallar cup discrepancy over here. So these are the patient, same eyes of patient, and inferiorly wedge defect is there in this patient. So this drawing helps us in identifying these defects, so we can see where the bayoneting is there, because we see critically whenever you are drawing, you see critically for the signs of these patients. Now you know almost everything. So, and even the circumlinear vessel, if it is bared, you can just point out and watch for this. You have to watch for disc changes if you are following a glaucoma patient. And now see here, is this a normal patient? There is subtle disc hemorrhage over there and excavation of the neuroretinal rim over there. So we followed up this patient. You can see that there is disc hemorrhage is absorbed, and there is disc hemorrhage at a different location. And now this has been developed into a subtle RNFL thinning inferotemporally. So if you follow up these patients, you will know how the disease progresses also. So what you see in books, what you read in books can be true when you are following these patients over the time. So next example, a patient came for routine eye exam, 52-year-old male patient, and pressures were normal, slightly higher teens. There was early NS and vision was 6.6 N6. But if you look at these optic nerve photographs, you can see that there is thinning of RNFL here and very thin neuroretinal rim. There is lot of atrophy, peripapillary atrophy over here. Though the pressures are normal, this is a typical hallmark of normal tension glaucoma. So when we did gonioscopy and other things, again the diurnal fluctuation was not very high, gonioscopy was open. So this can be a patient, and now see, look at the red-free photographs over here. There is RNFL thinning almost in superiorly and inferiorly in both the eyes. So this is a typical patient of normal tension glaucoma and needs investigations and follow-up. A next patient, now here you can see that the neuroretinal rim here looks okay, but inferiorly there is thinning or notching of the neuroretinal rim. Here also temporally you can see, and there is bayoneting of vessel over there, and in RNFL you can see that there is a wide wedge defect over there. So left eye definitely is having glaucomatous optic neuropathy, and we have to do further investigations for this patient. Obviously there are certain discs which are like difficult to see whether they have glaucoma or not, and where they have to be followed up by different means. You cannot follow up these patients even on perimetry or OCT, and you have to follow up these patients only on pressure and optic nerve head photographs to see. Some of them may not be glaucoma at all, like this. If you see, this is a disc where the pallor is much more as compared to the cupping. So, and even the cupping is not good. So this can be something else and not glaucoma. So all these patients you have to follow up very carefully, and before labeling them as glaucoma, please investigate. Large discs obviously should not be ignored. So these are the discs which we had shown you in the earlier slides. So if you investigate them, now you can see that the fields are totally normal, and patient has large discs. They are more than 3 millimeters. The disc area is very large. So this is a high large disc with a high CD. So obviously not glaucoma. Next patient, again a moderately high CD with large cup, and when we investigated this patient had very advanced glaucoma. This is a central 10-2 field, very minimal, almost less than 5 degrees remaining, and that is also temporal. So they can have very advanced glaucoma, and this is again a similar case with a moderately high CD and moderately large cup. And when we investigated this patient, can you see what is this? So I'll just shift them, and now you know what it is. It is a neurological defect. So these patients should not be ignored, should not be just labeled as high CD and just kept aside, but you have to do at least perimetry for these patients to come to a conclusion whether they are normal or not. So this patient had pituitary adenoma. So ONH evaluation helps us in identifying not only glaucoma but some other diseases also. You have to develop a skill of our evaluation and draw diagrams of ONH. Obviously have to document them digitally. We can evaluate them, enhance them, and see at a later date whether they really have some problem or not. And you have to correlate all these with the RNFL the defects over there. So disc size is important because it affects the apparent neuroretinal rim. Neuroretinal rim is important and not CD ratio, and you have to correlate again, emphasizing with retinal nerve fiber defect. Thank you for patient hearing.
Thank you, Dr. Medha, for that elucidating, for describing in detail what are the things that you need to look out for in optic disc when you are suspecting glaucoma. So before we move on to the next talk, I would like to invite any questions for Dr. Neeru Gupta's keynote address, because she has to attend to another hall. If there are any questions for Dr. Neeru, she will take it. Three.
Yeah, small is less than 2, 2 to 3 is moderate. Small is less than 2, 2 to 3 is moderate, and more than 3 is large, according to European Glaucoma Society. Yeah.
Yeah, just one question.
Any questions for Dr. Neeru Gupta?
Dr. Neeru?
Yeah, just one question.
Dr. Neeru,
Is
there's a
what is
question for
the
you.
evidence of primary damage for glaucoma? Or primary evidence for glaucoma damage? The optic nerve signs, is there anything as first, second, and third, or do we need to focus?
So
Yes.
the question was, what is the evidence for primary damage in the central visual system? Is that your question?
No, I'm sorry. I was asking to the previous talk.
No, we'll take the questions for Dr. Medha later on at the end of the IC.
Oh,
We are
alright.
inviting questions only for Dr. Neeru because she has to leave.
All right.
But if we start questions, we won't be able to finish IC on time. So any questions for Dr. Neeru Gupta? So thanks a lot, Dr. Neeru. You have covered your talk very nicely. There are no more questions.
So I invite Dr. Amit Purwal to speak on the topic of understanding posterior segment OCT in glaucoma along with structural and functional correlation. Once you suspect a defect after examination of the optic disc, would you like to correlate it by imaging technology to be sure before you move on to the visual fields? Dr. Amit.
So I'm going to talk on understanding posterior segment OCT. This is very important because nowadays OCT has become a very common diagnostic test which is performed by everybody. Most of them have an OCT machine and everybody gets an OCT printout. But how to interpret it, I'm going to cover in detail about that. I'm going to show some cases about correlation between the OCT and the visual fields. So got no financial disclosures to be made. So we all know OCT is a technology that assesses the health, structure and thickness of the retinal nerve fiber layer, the optic nerve head and the ganglion cell layer. It gives a quantitative analysis of the above mentioned structure and it is accepted as an hygiene tool in assessing and monitoring glaucoma. So earlier when the OCT machine started, it was a time domain OCT machine. This is how the machine looked like and this is how the printout looked like. But over the time, the technology has evolved and there are a lot of newer softwares and every machine has their own software. So currently the most commonly commercially available SD-OCT devices are the Series SD-OCT, the RTView100, the Spectralis OCT, the top one 3D OCT 2000. So each machine has different glaucoma scan patterns, proprietary software segmentation algorithms and display outputs. So data of one machine can't be compared with that of another machine. This is a very important point which all of us have to understand, that the data of one machine can't be compared with that of another machine. So if you are taking an OCT test of a patient on one particular machine, you always have to repeat the same test on the same machine, I mean the same company. You can't compare the data of two different company machines. So a brief introduction of OCT. It is a non-contact, non-invasive transpapillary device. A near-infrared light beam, 820 nanometers, projected onto the retina. This light gets reflected from the boundaries between microstructures and also gets scattered differently from tissues with different optical properties. So it then compares the echo time delay of the same wavelength that is reflected from a reference mirror at a known distance, and an image display is in grayscale or a false color scale is displayed. So different color represents the degree of light backscattering from different depths of the retina. So coming to the spectral domain OCT, I am a Zeiss user, I have a SD-OCT, so I'm going to talk most of it on Zeiss printout. So the clinical applications, what are the clinical applications for glaucoma of OCT? You can do the nerve fiber layer analysis, the optic nerve analysis, the ganglion cell analysis. You have the GPA, that is a guided progression analysis. You also have anterior segment imaging by OCT with the anterior segment premier module, and you have a combination analysis from HD-OCT and Humphreys visual field also. So that is the forum. So coming to the HD-OCT analysis report, it offers qualitative and quantitative information and in an easy to read out format. The analysis results can be printed, viewed via review software, or can be integrated with other instruments data to the IK data management system. So RNFL and ONH evaluation, that is the optic disc cube of 200 by 200. What is this optic disc 200 by 200 cube? This scan of the optic disc captures a 6 by 6 millimeter cube, which is formed from 200 A scans for each of 200 B scans. Okay, the area within this 6 by 6 millimeter is segmented for analysis, and from this cube of data, the machine automatically identifies the center of the disc and creates a 3.46 millimeter calculation circle around the disc. The RNFL thickness along this peripapillary circle is analyzed and compared to the normative data. So, coming to the optic nerve head calculation, the optic disc edge is determined by the termination of the Brooks membrane, and the rim width around the circumference of the optic disc is then determined by measuring the amount of neuroretinal tissue on the optic nerve. So this is how a printout looks like on the another. Once you take the OCT scan, the analysis screen shows this type of image. Now, this is a whole printout, the ONH and RNFL analysis report. I have divided this whole printout into various zones. So zone 1 is the patient data, zone 2 is the key parameter, which the key parameter is compared to the normative data and are displayed in a table format. Zone 3 has an RNFL thickness map, it is topographic display of the RNFL. An hourglass shape of yellow and red color is typical of a normal eyes. Zone 4 is the RNFL deviation map, which shows deviation from the normal. Zone 5 is the neuroretinal rim thickness profile, which is matched again to the normative data. Then you have the RNFL TNST graph, which displays patient's RNFL measurements along the calculation circles compared to the normative database. Zone 7 is the RNFL quadrant and clock hour wise. So you get the superior, inferior, digital temporal quadrants, and also each clock hour wise it is displayed. Then you have the horizontal and the vertical V scan, and you have the RNFL calculation circle. So basically this is how the whole, like how we divide the visual fields into different zones. We also divide the OCT picture or the OCT printout in various zones. Now coming to one of each zone individually. So zone 1 is the patient data, which shows the image quality and the signal strength. It is very important. You have to type the same name whenever the patient comes for follow-up. There should be caps lock. You should make it sure that whenever you want to enter the data, whether the caps lock is going to be on or off. So you should have the same name. You should have the right age, because it is again age matched, and you should always have a very good signal strength. The signal strength displays the image quality. I've already showed what is the signal strength. I'm going to come out it in the later this thing. So when you look at the key parameters, there's normative comparison, which is based on the patient's age and disc size. For a particular age and disc size, the patient is expected to have a rim volume, a CD ratio within a certain range. So those parameters shall be shaded red, yellow, and green based on how they compare to the normal ranges. So the disc area will always be shaded in gray on the OCT printout. This is the table which shows the normal range. Dr. Saroj was asking what is the disc area. The normal range in the OCT is 1.3 to 2.5. So anything less than 1.3 is a smaller disc, and anything more than 2.5 is a larger disc on OCT. So when the disc area is outside the normal limits, the normative data comparison is not applied. This is very important. So when there is no normative data comparison, the parameters are shaded in gray instead of red, green, or yellow, as shown in this example. You can see this OCT printout, everything is in gray. So coming to the RNFL quadrant and clock hours, you get the whole display of the RNFL in various quadrants, and there's also an age-wise normative data comparison for that. The inferior quadrant being the thinness, the range being 96.6 to 145.5. So what does this color means? The OCT fundus image with deviation map, it facilitates the discussion with the patient, like how we have the visual field printout, the grayscale. In the OCT also, the OCT fundus deviation map, it helps in discussing with the patient that, see, this is your nerve is lost in this area, and they can correlate with the visual field and discuss with the patient. So you have RNFL peripapillary thickness profile, which is shown, for each eye, providing easier visualization and comprehension. So the color-coded indication of normative data comparison for RNFL and ONH, the distribution of normals, the thickest 5% of the measurements fall in the white area. The 90% of the measurements fall in the green area, and the thinnest 5% of the measurements are falling in the yellow area or below. The thinnest 1% of the measurements fall in the red area. So measurements in red area are considered outside the normal limits. So ONH values will be shaded gray if disc area is not within the central 90 degree of the normal range. So what are the limitations of the OCT? Basically, the art of finding and interpreting the artifact is very important. Everybody can have a printout, but you should know how to interpret this printout. So there can be acquisition dependent artifacts, there can be database related artifacts, the disease related variations, and other occult confounding factors. So when we look at the acquisition dependent artifacts, you have the signal strength, the scan quality, which I mentioned earlier, the key parameters. The scan quality affects the OCT performance. The effect is greater on RNFL than on optic nerve head or the ganglion cell layer. So the best quality scans, the signal strength should be more than 8, minimal acceptable is greater than 6. So each machine has its own signal strength. Size has from 1 to 10, the other machines have from 1 to 100. So you have to read your own manual of the OCT machine and know what is the range, or what is the values given. So do not compare the signal strength of two different machines. There can be technical errors that the signal strength can be variable due to the disc decentration, the eye movements, or the microsaccades or the blinks. This can cause acquisition dependent artifacts. Now, what are the database dependent artifacts? You can have a red disease or a green disease. So when you have a red disease, it is basically a misdiagnosis. And when you have a green disease, it is missed diagnosis. So the color code determined by the database of the instrument again. So what is red disease? A diagnosis of glaucoma based on mistaken identification of an area as abnormal. Patient is not represented in the normative database. The RNFL thickness falls outside the normal range, which is shown as red color. And in refractive extremes like high myopia, you can have this red disease. So what is green disease? A missed glaucoma diagnosis because the OCT appears normal. Okay, there is a small focal area. You can see in this photograph, in this pictures which are displayed, there is a small focal area of damage which is shown up as, this shows up as green. The instrument averages the thickness in a particular sector. So in this field, there is a focal damage, but when you look at the average RNFL thickness, it is showing as green color. So the focal damage is missed. So it is not that you should only look at the gross RNFL thickness, you should always look at the clock hour also and see where is the focal damage. Because a lot of time this focal damage is missed because of the overlying retinal glial tissues which shows in green color. So you can see in this particular picture, the gross RNFL thickness is shaded in green, but when we look at the clock hours, you can see that it is shaded in red. So if the age of the patient is less than 80 years, all parameters are in white because there is no age matched database. Like Zeiss machine, the age limit is 18 years. Anything less than 18 years, it can't be age matched. So the whole printout comes as a white in color. Now disease related variation, you have the floor effect. Now what is this floor effect? With advanced loss, the RNFL thickness levels off and it rarely falls below 50 microns. So at this level of the disease, the serial visual fields are more useful than going for an OCT. So if you have anything less than 50 microns, no point in doing an OCT again and again. You have to monitor this patient by serial visual fields. So do not do an OCT in advanced glaucoma. Now coming to the media opacities, area in which data is missing due to an opacity are represented in black on the NFAS SLO image. You can see in this image, there is a vitreous opacity and the image is, the shadow of it is seen as black in color. Coming to the segmentation error, it is important to look for the proper placement of the segmentation line produced by the SD-OCT machine software algorithms. These lines should not come together. They should go to 0 or at infinity. They should not meet at one another. The segmentation errors are more common in the presence of poor signal strength, tilted disc, cephalomas, large peripapillary atrophy, and posterior vitreous detachments. So you can see at different signal strength how these lines are going. Now coming to the guided progression analysis, I'm not going to cover in detail because this is going to take a long time. Again, you have a GPA printout, and again you have to divide in various zones. You have the zone 1, which is the RNFL thickness map. You have zone 2, which is the RNFL thickness change map. Zone 3, the average RNFL thickness. Zone 4, the RNFL thickness profiles. And 5th is the RNFL summary. You have to remember that the RNFL thickness map progression is best for focal changes. The RNFL thickness profile progression is best for broader focal change, and the average RNFL thickness is best for diffuse change. These three lines are very, very important. If you understand these three lines, I mean, the whole printout is very easy to read. Now, coming to the ganglion cell analysis, it adds complementary information to standard RNFL and OH analysis. Now, this ganglion cell analysis is gaining a lot of importance because that shows the early signs of the glaucoma. It provides an assessment of the structures essential for central vision. It shows deviation from the normal population also. And different machines calculate different layers of the ganglion cell analysis. So again, you have to remember, this particular sentence is very important. One machine calculates a different layer, the other machine calculates a different layer in the GCA. So measuring the thickness of, for the sum of the GCL, that's the ganglion cell layer, and the inner plexiform layer using data from the macular cube scans. The RNFL distribution in the macula depends on the individual anatomy, while the GCL IPL appears regular and elliptical for most normal individuals. So proprietary algorithms are adopted for specific anatomy, use GCL and IPL thickness. Now this is how the GCL map comes out, the printout comes out. Now what are these? This is a thickness map. It shows the thickness measurements of the GCL and IPL in the 6 by 6 millimeter cube and contains an elliptical annulus centered around the fovea. Then you have the deviation map, which shows a comparison of GCL and IPL thickness to the normative database. Then you have the thickness table, which shows the average and minimum thickness within this elliptical annulus. Then you have the sector maps, which divides the elliptical annulus of the thickness map into 6 regions, 3 equally sized superiorly and 3 equally sized inferiorly, and the values are compared again to the normative database. And then you have the horizontal and the vertical B scans, and basically this is how we are going to go ahead with the glaucoma patient. We need to evaluate the disc properly, get a disc photographs. That's the best way to save the data. take the disk photographs, the red-free photographs, take the visual field. If you have the forum, take the OCT, the GC ganglion cell analysis, and combine it under this software, and everything is seen together on the screen. And this is how you are going to evaluate your patient. It can't be only based on visual fields or OCT or only on disk evaluation. A combined correlation is very important. So coming to the structural and functional correlation, I'm just going to show some reports of OCT and visual fields and correlate them and show them to you all. You can see this OCT. This has the inferior quadrant is red in color. This is an inferior RNFL defect, and it is correlating with your visual fields. There are superior arcuate scotoma in the corresponding visual fields. So this is a very good correlation. The OCT field is very good, and always remember to mention the central corneal thickness whenever you are giving the reports to the patient. Usually what happens when we get the patient carries the OCT and the fields report, but the corneal thickness is not mentioned because that is lying with the doctor in his file. So always make it a habit to mention the CCT on one of these reports so that the doctor doesn't have to repeat the test. Now in this particular field, you can see there's a temporal field defect, whereas the gross RNFL thickness is normal. But when we look at the clock hours, there's a temporal field defect, and which is correlating with the grayscale. But the fields are normal. So what do you think? What is it? Can I have anybody from the audience? I mean, what correlation is it? So this is a pre-perimetric glaucoma. Your fields are normal, but the OCT detects the changes earlier. The structural defects are detected by the OCT earlier. So this can be a pre-perimetric glaucoma. Again, this is a field where everything is green. In the left eye, there's a superior this thing. But when we did the OCT, what is it? This is a neurological field defect. This is respecting the vertical meridian. The OCTs are normal, but these fields are respecting the vertical meridian. So these are a neurological field defect. This superior inferior, the superior defect in the right eye is more than the inferior defect. Did the fields are normal. What happened? We repeated the fields because the fields are not normal. Sorry. These fields were normal, and I think the next case, yeah. Again, the same thing. The field defects on the OCT, on the RNFL defects, and the OCT on the visual fields, they do correlate. These fields were abnormal, but the OCT, they are not coinciding with the OCT. We repeated the fields after giving some rest to the patient for some time, and see the fields are normal. You can see earlier there were so much of field defects. The fields were not good. There were a lot of errors. We advise the patient, we again counsel the patient what she has to do, how she has to perform the test, and then we get a normal fields. So you have to be very careful. Everything, sometimes the OCT might be normal, the field defect might be more, but you have to correlate and try to understand, is there any pathology, is the patient performing the test properly, or we need to recounsel the patient and re-perform the test. This is very, very important. So this is an advanced field defect. As I told you, right eye, red disease, the RNFL thickness is very less, and there's a macular split in the right eye, and we have to follow this patient serially by visual fields, and not by 24-2, we have to follow the 10-2 program in this case. Again, left eye is a red disease, but you see the fields are normal. Okay. So we need to correlate properly, and then when you do multiple fields, you take the GP analysis. This patient was basically a young patient. He had a pressures of about 32 in his left eye. The OCT showed RNFL defect, gross RNFL thinning. Clinically, the disc, I don't have the disc photographs. Clinically, the disc showed cupping, but the fields, he is being followed from almost 5 years. The fields are showing normal. You can see this progression analysis report, what I'm showing. His fields are stable, but his RNFL field defect was there in his left eye. And this is how we are going to correlate both the OCT, the visual fields, the disc photographs, and comprehensively we have to come to a diagnosis of glaucoma and manage them properly. Thank you.
Any questions for Dr. Amit? We'll take 1 or 2 questions before we move forward to the next talk.
Now I would like to invite Dr. Manoj Mathur to speak us on interpretation of functional correlation and structural defects in glaucoma along with visual fields.
So the glaucoma diagnosis depends on structural and functional correlation. Regarding the structural suspicion, we have heard Dr. Medha speaking to you about the minute details, what you need to look out for to suspect glaucoma, and then how to corroborate it further by OCT by Dr. Amit Porwal. Now, once you establish a structural defect, now you need to functionally correlate that defect before you finally come to a conclusion that this patient has glaucoma. So I shall be speaking about the interpretation and functional correlation of structural defects in glaucoma with visual fields. So first, let us go on to interpret a visual field C24-2 printout specific for glaucoma. If you see, this printout is divided into 8 components. Number 1 is the type of the test, patient demographics and clinical characteristics. Number 2 are the reliability parameters that are given here. Number 3 is the gray tone chart that is useful to help, useful to explain to the patient. But basically, as glaucomatologists, as ophthalmologists, zone 4 and zone 5, that is the total deviation and probability plot, and the pattern deviation probability plot are the heart of the printout. We need to look at these things first before we go on to correlate with the other things. The other thing is the global indices. Then the 7th one is the glaucoma hemifield test. And last but not the least, the raw data that helps you to come to a final conclusion. So let us go on step by step. Here we are seeing the type of the test, is C24-2. We have to understand that C signifies central, 24 signifies 24 degrees from the fixation spot, and -2 is only a notation. 24 degrees superiorly, temporally, and inferiorly. But since we expect a defect in glaucoma in the nasal step, on the nasal side, the field extends up to 30 degrees. The demographics, the patient's name and the date of birth should be correctly entered in order to retrieve. MC Mathur cannot be written as Manoj Mathur subsequently, for example. ID number, the date of the test, the start time, and the test duration, these all constitute the demographics. And the clinical characteristics. Which eye is tested, whether it is the right eye or the left eye. The stimulus size 3 is kept as a gold standard. If you change the stimulus size, you lose the advantage of StatPack analysis. The background illumination is kept constant at 31.5 apostils. The fixation monitor is the blind spot, but in patients where you suspect there is a central scotoma, the fixation diamonds can be used, and currently CETA standard is the standard strategy that we adopt for assessing the visual fields. The age interferes with the sensitivity. Every 1 decade, there is a fall of by 1.5 diopters drop. If you ask the patient the age, the patient says 35, you enter 35, whereas the real age is 50. So what the test taken by the patient is compared to the normative database of age 35 years, and then you get a diffuse suppression. That puts you in a quandary. Pupil size should be at least 3.5 millimeters for a correct assessment of visual field. It can be a little more dilated. You can adjust the lens, but generally you must avoid visual fields in a myos pupil. The treatment, that the lens that you put in the holder should be slightly more, 0.5, that is to relax the accommodation. And the foveal threshold sensitivity in decibels should always be measured. Abnormal values are flagged statistically. Now, you have, when you see a printout, you know that this test belongs to this patient, where what eye is treated, and once you confirm that the test belongs to that patient, the next question that you need to answer is whether the test you are looking at is reliable or not. If it is unreliable, no point in interpreting it. So the reliability parameters are determined by the 3 components: the fixation loss rate, the false positive rate, and the false negative rate. The fixation loss rate implies that periodically, a light stimulus is projected in the area of the blind spot. If the patient sees it, that means the patient is not fixing properly. Number 2, the false positive rate. Whenever a stimulus is presented, the machine also gives a click sound. Occasionally, the machine projects a click sound but doesn't project a light stimulus. The patient sees it as seen. That means that it is a false positive, and it indicates a trigger-happy patient. And the false negative rate, contrary, the patient starts off the test well, subsequently gets fatigued, gets tired, and the machine projects a 6 decibels brighter stimulus at that point. The patient doesn't see. That constitutes a false negative test. The gray tone chart, it is a display of a map of all test points and locations with assigned interpolated values. Points are measured 6 degrees, but the values are assigned at 1 degree intervals. The interpolated values are assigned at 1 degrees interval. If you see the print out here. Olden days, the prototype machines in the late 90s, they used to carry this grid. If you see here, the brightest light stimulus, when it is perceived by the patient, that means the sensitivity is the lowest, and that is the black. Whereas the highest sensitivity value, that means the dimmest light stimulus seen by the patient is seen as total white. And in between, there are 8 different shades of gray. More better the sensitivity, brighter the gray tone chart. The heart of the printout, as I told earlier, is the total deviation and probability plot and the pattern deviation probability plot. What is a total deviation probability plot? It is nothing but it has a numeric and probability displays, represents the difference between the measured threshold for each test location and the age-corrected normal for that location. And it is abnormal if the difference is more than 5 decibels for that age. Near the edge, especially in superior hemifield, a difference of 5 decibels is considered okay. Probability plot is linked to probability value symbols. What it entirely means is, what is the mean numeric display? If suppose the expected normative database at this point is 36, patient has tested 34, that means it gives you a value of -2. If the expected value is 34, patient has tested 34, that reflects as 0. If the patient expected value is 36, patient sees 37, that is reflected as +1. So it is a numeric display, and the arithmetic mean of all this translates in your global indices for the mean deviation, where it doesn't make any sense for you to see these numbers here. So they converted these difference of sensitivity values into probability symbols from 5% to 0.5%. What is probability value for less than 5% means? It is that kind of a defect that is seen generally in about 5% of the population. And conversely, P less than 0.5 implies it is that kind of a defect that is seen in only 0.5% of the population. Hence, now when you convert these numerical values into probability symbols, you get some information as to what is the kind of field defect that you are encountering. The pattern deviation and probability plot. Like the total deviation probability plot, pattern deviation represents the difference between the adjusted threshold for each test location and the age-corrected normal for that location. What is this word adjustment? Adjustment implies general change in the least damaged portion. It removes the general component of suppression from the disease so that the focal glaucomatous defects gets projected. And what is this value? Usually it is the 7th highest value in the raw data that is considered as a cutoff. Anything about that is general suppression, and anything below that is considered focal. So now, correlation between total deviation and pattern deviation. I always give this analogy whenever I am giving this talk. Suppose if I am crossing a road, I have a fall, I sustain a hand injury. As a result of this hand injury, I go home, and by evening, I become too tired, too sick, and I develop fever. When you visit me in the evening, you find me totally ill. But you are intelligent. You are saying, oh, no, this is all natakbazi he is doing. You remove the fever component and the malice component of from my disease. What stands out will be my hand injury. This is exactly what the machine does. The total deviation plot, the total depression, the total suppression of sensitivity is shown in the total deviation and probability plot. Whatever the diffuse component suppression, it can be nebula, it can be flare, it can be lenticular sclerosis, it can be vitreous degenerations, it can be chorioretinal degeneration, whatever component of diffuse suppression, when you remove that, what stands out is the pattern deviation probability plot, and the real focal glaucomatous defect is seen in the focal, in the pattern deviation plot. So if you see these 3 fields here, if gray tone chart shows diffuse suppression as corroborated in total deviation with all points being normal, that means there is no focal defect, everything is diffuse, that is most likely to be a cataract. Now, if you see this defect, inferior arcuate defect, as corroborated in total deviation with significant persistence in the same way, it is probably a case of glaucoma. If you see here, the gray tone chart shows a dense superior arcuate defect with diffuse suppression as corroborated in total deviation. When you remove the general component of suppression from this, the real focal glaucomatous defect stands out. So this is how you must corroborate by seeing the pattern deviation first, corroborate it with the total deviation, corroborate it with the gray tone chart, and then look out for the values in the raw data. Now, the global indices. As I told you earlier, the mean deviation is average, average numbers displayed in the total deviation plot. Mean deviation index indicates the overall sensitivity of the field loss. You want to give one value to how much this field is deviated from the age normal. One value, if you want to define, it is nothing but the arithmetic mean of all the values that you get in total deviation numeric plot. Now, the pattern standard deviation is a measure of amount of localized depression as compared with the age-matched controls. A low PSD indicates a smooth hill of vision, whereas a high PSD indicates a local irregularities. And the defects should be associated with the probability symbols. In the new machines, there is another parameter which is called the visual field index, or the VFI. This index expresses the visual field status as a percent of normal age-adjusted visual field. The moment you tell your patient that you may be probably having glaucoma or you have glaucoma, the first question the patient asks is what percent? So this one measure gives you an indication as to what is the probable percentage of loss for your patient. Now, the glaucoma hemifield test, it is calculated by comparing 5 zones in the upper hemifield with identical locations in the inferior hemifield after adjusting for the general height of vision. And it gives us information about the threshold value between the two halves of the field. And the 5 glaucoma hemifield tests that you get in the visual field printout are within normal limits, general reduction of sensitivity, abnormally high sensitivity, outside normal limits, and borderline. So what does it mean? If the sensitivity overall, there is no significant difference, and the sensitivity is within 99.5% of the range, it is within normal limits. If the sensitivity is such that it falls in the 0.5% of the range, it indicates a general reduction of sensitivity. And if the overall sensitivity is higher than 99.5% of the range, that is, the highest damage that you detect in the visual field is still being falling in the 99.5% of the range, that means it is hypersensitive. Whereas by glaucoma hemifield test, if the difference between the two halves is greater than that would occur in 99% of the normal population. That means if the difference between the two hemifields is such that it is seen in only 1% of the population, it is outside normal limits. And if the difference between the two hemifields is such that it is seen in 3% of the population, that means the defect is slightly less, and that constitutes your borderline. So these are all the 5 tests, glaucoma hemifield tests, that you get in the printout that helps you to diagnose glaucoma. The raw data is the display of all threshold values measured at every point. And you diagnose glaucoma by Anderson's criteria. But if the defect in your visual field satisfies these 3 criteria, then you can suspect glaucoma subject to structural correlation of optic disc. Now, if you come to reporting, if you see this report, if you want to diagnose this report in 2 sentences, the gray tone charts shows a incomplete superior arcuate defect with focal nasal step defect as corroborated in total deviation with significant persistence in the same pattern in pattern deviation that is most likely to be glaucomatous. Now, if you see moderate to severe, the 2 symmetrical field defects, superior dense arcuate defect with macular encroachment as corroborated in the deviation plots, and now total deviation in total suppression in 24-2 printout, but if you see here, the patient's vision is 612, so all these patients, whenever there is a macular encroachment, subject this patient to a 10-2 printout. This gives you the real pinhole vision that the patient is having 612 vision. Now, if you see this, the machine first tests the 4 cardinal points. The patient has not understood the test well. The 4 cardinal points are depressed. On subsequent explanation to the patient started doing the test properly. This is nothing but your learning defect. Now, if you see here, there is biarcuate suppression, but if you see subsequently, the reliability parameters, the false negatives are 57% and 59%. That means the patient has not responded to brighter stimulus at a subsequent stage. And if you look at the gray tone chart, this is the classical clover leaf pattern that you see, and that is the thing that it reflects the fatigue effect of the patient, and if the test becomes unreliable. Similarly, like this thing, when you repeat the test after 1 hour, this was the outcome. And now you see here what I was talking about, the hypersensitivity. The total deviation is much better than the pattern deviation. What does that mean? This man is superhuman. And when you correlate the raw data, you see values like 47, 48, 46, and you see the gray tone chart, there is a white scotoma. This indicates hypersensitivity the documentation. This was my old machine, which I used to do fields myself 2 decades back, and I detected this. The patient had 0.6 cupping and intraocular pressures of like 22, 23. I started the patient, I diagnosed this as an inferior arcuate defect, and then patient was all right. Patient came back to me after 6 months. I repeated the fields, then I saw this. So what does it mean? Like now I realize that this patient is having an inferior quadrantanopia. So had I known the lesson that I learned first time when I diagnosed this only on the gray tone chart in my learning days as an inferior arcuate defect, had I not seen the gray tone chart, what I said, the heart of the printout is here, not here. Had I looked this 6 months back, it was a classical quadrantanopia, which I missed. So the lesson that we learn from this is any vertical separation is neurological, any horizontal separation is probably glaucomatous. So now, having understood that, I stopped looking here, I started seeing here. This is a classical superior arcuate defect, and then when you go to the gray tone chart, you see a definite vertical split. And if you see 0, 18, 0, 20, so that means there is a definite neurological split, plus there is a possible early arcuate separation. So synopsis, give a preliminary look at the gray tone chart and the foveal threshold, corroborate it with the total deviation plot, look out for significant persistence in pattern deviation plot, confirm this defect with the PSD and CPST, and then analysis of the raw data, and then this defect should then be correlated clinically to OD change and other parameters. Only then you can diagnose this as glaucoma. Having learned how to interpret visual fields, let us now move on to the correlate, structural and functional correlation in OD. As Dr. Medha said, the first thing that you must look out in an optic disc is the size of the optic disc. This is the fovea. If you put one disc here, it overshadows this is a very large disc. What is important is not the size of the disc and the cupping. Earlier days, in 2 decades back, we used to diagnose this as glaucoma, but now we realize what is important is the health of the neuroretinal rim through which the 12 million axons are passing, and not the size of the disc and cup are interrelated. And it is a surrogate for neuroretinal rim. It is the health of the neuroretinal rim which is vital for structural diagnosis in glaucoma. So if you see this large disc with a large cup of 0.7, still the visual fields are normal. Similarly, on the other eye. Now if you see this, there is a notch here, this dipping of the vessel here. If there is a slight notch here, then that is reflecting as a focal defect in the superior nasal step. This is how you correlate. The first thing that you see is the same. If you see the field here, conversely, you are seeing a focal defect in the nasal step inferiorly. On careful evaluation of the optic disc, you see a notch here. So this is how you structurally and functionally correlate cases of glaucoma. Whereas if you see the field here, there is a dense inferior arcuate defect, and if you see the disc here, the superior rim is totally excavated and pale. Now if you see here, if you ask you to interpret this, now there is every chance if you see it through a direct ophthalmoscope, the color cupping is only about 0.5, but as Dr. Medha said, it is the dipping of the vessel that is important. That gives you a clear contour cup mapping. So if you see here, this is a near total cupping which reflects in total suppression in the visual field. In such cases, you must do a C10-2 printout to correlate with this kind of a optic disc, the near total cupping. You still in 10-2, you have some sort of visual field left, and this should be helping you in future. Now if you see this is again a possible large disc, but if you see there is a temporal pallor, such cases, if you encounter temporal pallor in optic disc, always subject those patients to visual field. You will not be surprised if you get a homonymous defects. This is the other eye. So always bitemporal pallor in optic disc, subject that patient to visual field, you may get a structural and functional correlation by way of a neurological defect, need not be glaucomatous always. So if you see this defect, the disc here, now this disc, you are seeing there is a inferior notch which is reflecting in form of a retinal nerve fiber layer defect, and if you correlate it with the OCT, now again this inferior, this notch is corroborating with the inferior temporal, the thinning of the nerve fiber layer defect, which is again corroborating with the ganglion cell complex, and conversely the visual field is giving you a focal defect in the superior nasal step. This is exact structural and functional correlation by way of optic disc, by way of OCT corroboration, and then functional correlation in the visual field of an early case of glaucoma. Now again, if you see this disc here, you correlate with the OCT, you see the inferior thinning of the neuroretinal rim here, and the ganglion complex is corroborating, and the central corneal thickness is again showing a slightly thinner thing, and then that gives you a superior arcuate defect on the visual field. And now, in this disc, again, if you see, when you correlate with the OCT, there is diffuse retinal nerve thinning, and the ganglion cell complex is again involved totally. The visual fields are compressed. If you see this disc at the outset looks more like a normal thing, but the contour cupping is the thing. It is how you see that contour cup, how you mark out the contour cup, and then you corroborate that with the OCT, and then the visual field, that is most important. And now some interesting cases. Here if you see the IOP is 24 and 23, the CCT is like this. If you see here, there is excavation, not exactly, the sharp edges on the nasal side, not exactly. In glaucoma, generally you expect something on the temporal side, but here there is something on the nasal side which is sharp edges. If you corroborate with the OCT, it is perfectly showing, but it is in the superior nasal. Had it been superior temporal, we would have certainly tried to treat the patient, but I leave it to you with a pressure of 24, with sharp edges, with OCT corroboration, whether the visual field is normal, whether we would like to bring down the pressure to a certain extent, or would you like to follow up this patient. Again, a similar situation with this kind of a thing, the visual fields being normal. If you see the ganglion cell complex on both the eyes, subject to other pathological conditions, if there is none, if the ganglion cell complex is involved, then this study shows that 10% of these patients are likely to progress to frank glaucoma. So it is up to you to decide whether you want to treat it or not. Whereas if you see this disc here, like here the neuroretinal ring is somewhat okay, but here I had a definite suspicion there is something wrong. So when I did an OCT, OCT is absolutely normal. And visual fields, because I was not happy, I thought something is abnormal, I did the visual fields subsequently. Always the visual fields are normal, and I'm happy to maintain this pressure on the intraocular pressure of 23. You need not treat such patients. So this is how structural and functional correlation by optic disc, by OCT, and functional correlation helps you to come to a conclusion whether you need to treat any patient on individual case basis or not. Now, if you see this case, a 54-year-old with anterior segment normal, half ACT, and pressures of 19 and 14, this gave me a suspicion. Always an asymmetry between the two eyes. Why are the intraocular pressures 19 and 14 and open angles, and this was the kind of disc that I saw. Then I subjected the patient to visual field. Because of intraocular pressure asymmetry, I found the visual field normal. Then I did an OCT. In OCT, what did I see? In the right eye, 19 pressure, other eye was 14. In 19 pressure, there was a superior temporal thinning. Then I thought, oh, this is an asymmetry. I sent the patient, I asked him to come back after 3 months. When the patient returned after 3 months, I was wise enough. Was in my early days when of my tryst with the OCT. Then I knew about the GCC complex. So I wanted to take a printout with the GCC complex. I did it complimentary for the patient after 3 months. And on the second setting, again, then because of that superior temporal thing, I started seeing some sort of a new nerve fiber layer defect drop out here because there was a definite superior temporal thing, and I suspected that there is something going to be there. So when I repeated the OCT, I found this. Where is the superior temporal defect that was detected earlier? There is nothing. Now, what does it mean? The left eye is totally normal. I had a superior defect, and the GCC complex is also normal. Then I had a careful lookout of the two printouts, the earlier one, and this was the thing. Here, the OCT was absolutely normal. If you see here, what is it? It is the disc is absolutely centered. Whereas if you see here, I got the superior temporal defect only because the disc is decentered. Instead of checking the thickness here, the thickness is checked here. So OCT in itself is a good machine. OCT in itself, you cannot say it is normal, you need not. It is the person behind the machine. It is proper centering. It is person behind the machine that is important. You cannot say OCT is useless. Machines are machines. It is the person behind the machine. How you do the test, how you interpret the test is most important. So thank you for your patient hearing. I think we have 5 minutes. Any questions for all the three speakers? We'll be able to answer.
What's your suggestion? Does the functional defects come earlier or the structural defects come earlier?
Yeah, it is always the structural defects that come earlier, because once there is in the functional defects, what is known as, like by the time functionally the defect is seen, about 40% of the RGCs are lost. That is the general convention followed. The structural defect is always better, and that is the reason, that is the scope for OCT. Why we do OCT is to establish pre-perimetric glaucoma. That is the main aim of doing OCT, whereas as Amit outlined, there are so many things that you need to interpret in OCT also. Yes, that is called apoptosis, loss of retinal ganglion cells. Yeah.
Cell is devitalized, it will show a functional defect. Although morphologically it may look almost near normal. So I would think the functional defect should come earlier than.
No, like only after the loss of RGCs, the functional defect comes. Only once you lose structurally, then that area doesn't perceive the stimulus, light stimulus, and that reflects as a field defect. It is not a part loss of a cell. It is not, no. It is either the cell is alive or the cell is dead. An alive cell can perceive the light sensitivity. A dead cell will not perceive the light sensitivity. Light.
So the quite a few studies who have shown that the structural defects come earlier than the functional defects. Only few studies have been shown in the literature where they say functional defect comes first, then the structural defect. But most of the studies shows structural defect comes earlier than the functional defect. Yeah, one more question behind.
Hello.
Yeah.
Should we follow RNFL analysis or a GCC complex? Which is better?
GC complex gives early detection, but still it is an evolving procedure. RNFL is an established procedure.
Thank you.
Yeah.
If you do both, it adds value to your patient. I mean, you are getting glaucoma at a very earlier stage. So that's what I told. GCA is still in a evolving stage. A lot of centers have started doing this GCA GCA evaluation. So if you do both, it's very good.
GCC can be used as a surrogate measure. Suppose you have a RNFL inferiorly thinning down and you have a GCC there. So they are like support each other. Yeah.
Yeah,
Studies have shown that the GCA analysis as the defects come earlier than the RNFL defects. So early detection, GCA analysis is much better.
Subject to the condition that the ganglion cell complex is normal. There should be no edema, there should be no inflammation, there is no other pathology in the ganglion.
All the pathology in the macula should be excluded.
Then only then GCC has value.
All the pathology in the macula has to be excluded, and then it is helpful.
Yes.
Yeah.
Macula has to be normal.
Yeah,
then
ideally you
consider.
do macular scans also, because sometimes what happens is we are looking at only on the optic nerve, but can be some certain things going on behind the macula or the foveal center. So that has to be excluded, and that gets excluded when you do OCT. So better to do both together, as well to exclude the macular diseases as well as to see the GCC complex. Yeah, each and every glaucoma patients you do macular scan also. Yeah, but those can be picked up on different type of machines, perimetry machines, not on OCT. Yeah, not on. Yeah, perimetry, that matrix perimetry picks up magnocellular
Magnocellular.
pathway. So that is a totally different scenario. You have to look up for the other risk factors. So if there is a family history of very advanced glaucoma, someone going blind in the family, patient is like apprehensive, you discuss with the patient. And if other risk factors are present, you may start treatment based on there is structural progression of the disease. Someone asked me how much time it takes from structural to function. So it is noted that it takes 3 to 5 years. If you see a structural loss on OCT, to get a functional loss, you have to have at least 3 to 5 years interval. That much period is there. That has been shown in OHT study.
Basically, pre-perimetric glaucomas, the risk conditions, family history, thinner cornea, look at the age, and then you decide whether you want to treat or no. There, Weinberg had shown in WGCA, the World Glaucoma Congress, that every decade there is a degradation of the RNFL thickness. Okay, so pre-perimetric glaucoma, he had shown that when he followed for a long time, he advised it is better to treat. But then again, in our GSA, what we recommend is look at the corresponding risk factors and then decide. I think we are out of time
One
now.
final question.
final question.
Yeah, thank you. My question is in the same line that what is the primary evidence of glaucoma damage? Is it the that is pre-perimetry diagnosis instrument? Can we take as the evidence, or when do we investigate this pre-perimetric in where there is risk factors present? Like you mentioned, there is a family history of advanced glaucoma, but suppose I am the patient and you see my discs and pressures, so they are well within normal range. So would you subject me to RNFL GCC right now because I'm 40 plus, family history of glaucoma? Or you would like to observe and treat my other risk factors like diabetes, hypertension, and obesity, and non-ocular. And
Yeah,
then during the-
obviously,
so what
obviously
it
you
is.
have to treat other risk factors. But the most important thing is keep following up your eyes. Like you
So-
have to repeat.
So when is the
A base,
when would
I
you
would go
advise
for a
RNFL?
baseline fields and OCT. If you have a family history of glaucoma, even though clinically your fundus appears normal, I would still subject you for a baseline OCT and visual field.
So while you're observing, when on the next visit would you start treatment? What are the parameters or the early damage?
If your baseline fields and OCT are normal, I mean, we'll just evaluate subsequent follow-ups clinically. And might be after 2 years, we'll repeat the same investigations.
So the disc changes, evidence of disc changes is the basis for starting
Yes.
treatment? Is it
Yeah.
all right? Yeah.
Yes.
Thank you.
With structural correlation with OCT.
Thank you.
If the fields are
Structural
normal. If the fields are
progression,
normal.
even on photographs, like I had shown one patient. So structural progression even on disc photographs is a sign that you have to start treatment for this patient. You cannot wait for the patient to develop defects on perimetry and then start treatment, because already you have lost so many ganglion cells.
Yes.
So structural, if you document structural progression, then you can start treatment for the patient.
All right. Thank you.
Thank you all. Thank you all for attending this institution course. Thanks a lot. We end this session now.